Okay, hey guys, I'm Katie. I'm the president. Welcome to the third general body meeting. Today we have a really exciting special guest who's going to present. Who knows the most about her and who's been coordinating with her and making it all happen is our awesome advocacy chair, Alyssa Regalos. So I'm going to go ahead and give the mic to her.
Thank you, Katie. So today we have Dr. Jennifer Walker. She is the medical director for the East Hawaii Health Clinics. She practices family medicine and she has years of experiences in different healthcare settings and healthcare leadership positions. So I'm really grateful to have her today. And on behalf of everybody, we're really grateful to have you today as well.
That's great. Thank you so much for inviting me. Just for the purposes of planning, how much time are we planning today?
Up to I think 5 p.m. is
Okay.
usually when our meetings last.
So it just dawned on me when you said I have years of experience. I don't even really want to admit, but I graduated medical school in 1993. So do the math there. I've been around for a little bit. So I was sort of given a broad brush of give us a lecture about something that you have interest in. And I'm a family physician, and you guys may already have your own impression of what a family physician does. So this is sort of a thinly veiled recruiting ploy for, yes, I want you to go into medicine, and yes, I want you all to be family physicians. But I put this lecture in particular together following a conversation with a medical student. My position here at Hilo Medical Center includes training medical students and residents, and I was training a medical student from a different country that does not have family physicians. And so she didn't have at all the concept of what it is that we do. So I sort of put this together as a, well, why would you want to be a family physician? But more importantly, why would governments want to include family physicians in their health plans for their countries and for their communities at the smaller scale? And I was actually invited to give this lecture at a global health summit at the American Academy of Family Physicians just last month. So being little bit busy and maybe probably even a little bit more lazy, I'm just going to kind of go through the slides that I went through for that conference. And that was actually an international conference. And I was thrilled to know that there was enough interest in the topic of why family medicine that they wanted me to do it at that level. And I can see 5 faces on the screen, one of which is mine. I'm not sure if there's anybody else dialed in or there's other people in the room. If you guys have a question, please just say the words because I can't see this chat screen. Anyway, so we're going to identify different training requirements to be a family physician and kind of help you understand where we sit in global health and in particular addressing non-communicable diseases, and then how we address health promotion and sort of preventive medicine stuff. So let's just briefly go through. So true or false, with the thumbs up or thumbs down, family physicians are trained to care for babies and children. Thumbs up or thumbs down? Thumbs up, I see. Oh, okay, Alyssa's not gonna vote, ish. Okay, yeah, sure we are. We're trained to care for patients over the age of 65. Thumbs up, yes or no? Right, see? What about we're trained to care for patients with acute injuries and minor illnesses type things? Right, okay. What about for chronic illnesses? Yeah, of course. And then every organ system and pretty much any disease you could come up with, I can at least kind of put it together for you. Yep. And especially here in Hilo, we don't have a whole lot of specialists around here. So you really have to be prepared to address pretty much anything that walks in the door. We take care of people who have behavioral health conditions like depression, anxiety, that sort of stuff. True or false? See, Marvin doesn't think I do anything for a living. He thinks I just show up and look good, right? I'm watching you. And then we also participate in what we call disease surveillance programs. So we help with public health type stuff. True or false? That's also a true statement. All right, so There's an organization called WONCA, and it's a really strange acronym, but it's basically a World Organization for Family Physicians. And they have defined at the international level what are the core competencies of a family physician. And I'm going to go through each of them sort of step by step, because they really hold true, specifically in the United States. The first thing that we do is called primary care management, which means we are pretty much the first point of care for people when they contact a healthcare system. We address every age, any health problem, regardless of the gender, regardless if they have money, don't have money, they come from a small town, they come from a big town. We can coordinate care with specialists, but we're what we call primary care. Specialty care is maybe a dermatologist or an endocrinologist or an orthopedic surgeon. I do primary care. I'm the first point of when somebody needs to get health care. Our care is person-centered, which means I make recommendations based on the context of the patient's circumstances. So I ask people, do you have water running at your house? Do you have electricity at your house? Do you have enough food at your house? How often do you feel threatened, or are you safe in your house? These things matter because it doesn't matter how good I am at taking care of your cholesterol or your diabetes. If you don't even have water at home that's safe to drink, the rest of that stuff just doesn't really matter. The other thing we do on this bottom line here is we do what we call continuity of care, meaning I see people over and over again, maybe every 3 months, maybe every 6 months, maybe once a year. So I develop an ongoing relationship with them, maybe with them in the context of their family, maybe with them in the context of their education, or how's your job, or how's your career going, that sort of thing. Basically, it's taking care of the whole person though. We are expected to demonstrate specific problem solving skills. And one of them, I really like this quote, using time as a tool. There was a quote that basically the role of the physician is to entertain the patient until the disease runs its natural course. And for many of the things that many of us do, the body is going to heal itself if you just give it enough time. And family physicians recognize that I don't have to put a prescription in for every single problem. I don't have to get a specialist involved for every single condition or complaint. I can identify when it's an urgent problem, but I can also help the patient to sort of manage their expectations and use time as a tool. We take a comprehensive approach, meaning we take care of acute and chronic problems. So acute problems is, I have a stuffy nose, I have a hurt knee, I've got a really bad headache today. And then chronic problems is, I have diabetes, I have high blood pressure, I have depression, that sort of stuff. So I do a little bit of everything. We do health promotion, which might mean for young women, I say we got to do your pap smear. For a guy, it might be, I need you to get your tetanus shot because I know you're out there dorking around and you're going to get cut on something. If you're a smoker, I might harass you about stopping smoking. Even though that wasn't what you were here for, I'm also going to include that in your visit. We take the needs of the patient and put it in the context of the community in which they live. It would not be ethical for me to make recommendations for a patient that I know that they have no hope whatsoever of ever accessing. Like, I need you to, I'm going to prescribe massage therapy for you 3 times a week. Yeah, good luck getting that, because I know you can't afford it, and I know your insurance isn't going to pay for it, and it's not going to happen. So it's sort of cruel for me to even make those kind of recommendations, right? I need to consider what is available to you in your community. And then we take a holistic approach. And this quote here is from Barbara Starfield, who was a distinguished professor at Johns Hopkins, and she worked on health policy. And she pointed out, if health systems are to become more effective and more equitable, care has to be focused on the patient and not the disease. We spend a lot of money in this country addressing specific diseases, but it's a family physician that really puts it in the context of the patient. So I actually corresponded with WONCA, which again is this World Organization of Family Physicians. And I said, who do you have in your organization internationally that has academic departments of family medicine? So there's something like 210 countries, give or take, I think, over 200 countries in the world. And you could see here, it's like less than 10% of them have academic departments of family medicine that participate in this world organization. So back to my conversation that I had with the medical student a few months ago, it makes sense that there's people out there that don't even know what family medicine is. And it's interesting for me, the entire country of Russia does not have an academic relationship with Wonka for family medicine. The entire continent of South America does not have a department of family medicine that participates in Wonka. And you see much of Africa goes uncovered from family physicians. North America is pretty well covered. As you see here, we've got plenty of academic programs in America and plenty in Canada as well. So Wonka lays out what they say are the must-have components of a training program in order to get somebody prepared to do all of those core competencies that we just went through. They say that at least 50% of your training needs to be from other family physicians. Now, we have our residents train with surgeons and they train in the emergency room. They train with pediatricians, they train with OBGYNs, but at least 50% of their training needs to be with family physicians that are role modeling for them what the practice is going to look like. And you see the other must-have components that I kind of already sort of described to you, much of it regarding the core competencies. So in the US, family medicine training is a residency program that's 36 months long. It follows your 4 years of medical school. There's a minimum number of patients that you have to see in the outpatient clinic, 1,650. I don't know how they came up with that number, that was the magic number, but it's a way to demonstrate that you had a lot of experience with a lot of patients. And they put that you have a minimum of 10% of them are under the age of 10 and a minimum of 10% of them are over the age of 65 to demonstrate that you can take care of patients across the entire age spectrum. Even though Marvin was not certain that I knew how to take care of kids, I was trained to do it, and here's the proof. They're very, very specific in the US as to what it takes to get a family physician prepared through residency. And it's almost embarrassingly detailed. You have to spend 2 months in the ER. You have to spend 6 months on the inpatient medicine. That's like when people are in the hospital getting treatment for their COVID or getting treatment for their pneumonia or their kidney stone or their heart attack or whatever. At least 1 month in the intensive care unit, 1 month of geriatrics. That's like in a nursing home or in a long-term care facility. 2 months of pediatrics, both on the inpatient and then 2 months on the outpatient. We have to do OB, we have to do ortho, we have to do sports medicine, we have to do surgery. So back to my little true false question, right? This is how I can prove to you, yes, all of those things were true because any family physician that's board certified was mandated to go through this level of training. Now I thought, well, let's look and see what our neighbors to the north of us have to go through. In Canada, they have a 2-year residency training program that is also competency-based. And then they offer a 3rd year in sort of subspecialty training. That's sort of this right-hand column here. Maybe you want to do extra training in emergency medicine or geriatrics or sports medicine or addiction medicine. You could see here. So it's sort of a little bit of a subspecialty to sort of that 2-year general practice on top of it. So I want to segue a little bit. First of all, is there any question about sort of what a family physician does and how we get trained to do what we do? Hearing none. Alyssa, I'm going. Okay. So I want to segue into the role of family physicians in non-communicable diseases. But first of all, we need to back up. What are communicable diseases? There's a big one in the news right now.
Diseases that like are social, so like it can travel to different people from people.
Right, exactly. So they can be spread, and it might be spread person to person or person to a vector to a person. Like malaria, for instance, is a communicable disease that I can't give you malaria, but the mosquito that bites me then could come and bite you and give you malaria. or like rat lungworm disease, or like COVID. I sneeze on you and I'm going to give you COVID, right? So that's what communicable diseases are. So let's test to see how well you're paying attention. What do you think then non-communicable diseases are?
Is it those that are passed on by genetics or some sort?
Yeah, can you name one maybe? Thank you, Amy.
Name one. Color blindness? No.
Okay, that's what we would like to call that more of a condition than a disease because it's
right.
just a thing. But yeah, so that might be one.
What about Parkinson?
Which one?
Parkinson? Parkinson?
Oh, Parkinson's disease. Yes, that would be a non-communicable disease for sure. Thankfully, it's not that common, so I don't have to spend a lot of my time dealing with although just yesterday we had a patient with Parkinson's disease. Unfortunately, it was brought on by the medicine that he takes for his psychosis that affected his dopamine levels and caused him secondary Parkinson's disease. Yes, that would be non-communicable. You don't catch Parkinson's disease, right? It's not a malaria, it's not a COVID, it's not a flu. You just, part of it's bad luck and part of it might be genetics. You guys are going way too hard though. Think simple stuff. What's the #1 cause of death in this country?
Cancer, heart disease.
Heart disease, there, ding, ding, ding. What's another one?
Diabetes.
Diabetes, yay. What's another one?
Cancer.
Cancer, good. Okay, so that's what we're talking about. We're talking about those diseases that are the effect of genetics, of your own physiology, some of your behavioral factors like smoking, for instance, or obesity. These are the diseases that worldwide kill 41 million people each year. And granted, I know COVID is in the news, and any number of people that are dying from a preventable disease is too many. But look at this, 41 million people a year die worldwide from non-communicable diseases. And they don't have that on the news every day. And you're not walking around wearing a mask or anything to trying to prevent that. And this is not, I say the residents, it's not sexy, right? Talking about this stuff is not exciting, but it really makes a difference. And family physicians are uniquely qualified to deal with these diseases. And so in particular, we're going to look at cardiovascular disease, which is like heart attacks and strokes. We're going to look at cancer. We're going to look at chronic respiratory diseases, largely like asthma and COPD. And we're going to talk about diabetes. And if you have any questions, please sort of flag me down or something and we'll talk about that. So here is worldwide a map. This is from the World Health Organization, which is a branch of the medical branch of the United Nations, that depicts your probability of dying before the age of 70 from a non-communicable disease. Thankfully, in North America, we're doing pretty good, but the areas that are orange or red, you could see you have pretty high odds of dying before the age of 70 from one of those diseases. And the 4 diseases that I mentioned are probably cause about at least 80% of the deaths from non-communicable diseases. You know, the Parkinson's and some of that other stuff, yes, that's out there, but there's these 4, like the big 4 main NCDs, like what it says right here on this slide. Let's overlay that with the map from Wonka that tells us where we have academic departments of family medicine. Look here on the left, my chance of dying prematurely in Russia is pretty good odds if you were betting on it. Look, there is not a single academic department of family medicine in Russia. Maybe it's a coincidence. I kind of don't think so. Look at all of this area in Africa where my odds of dying prematurely from a non-communicable, this is not malaria, this is not HIV, this is not COVID, this is cancer, this is diabetes, this is a heart attack. And it's the exact same part of the world that there are no family medicine academic members in Wonka. Same thing here. Look at Brazil and South America. There's not a single academic member in Wonka in the entire continent. So again, it's a coincidence maybe, but it certainly kind of makes me think, I wonder if having more family physicians around the globe might help with some of these premature deaths. So there are 4 main risk factors that are modifiable that can lower a person's risk of dying from a non-communicable disease. So I can't change your genetics. I can't change whether you're male or female. I can't change that your mom had breast cancer and that puts you at higher risk for breast cancer, or your dad had colon cancer and died at 45, that puts you at higher risk. But there are behavioral factors that also put you at higher risk for these non-communicable diseases. They're listed here. They sort of are like, no, duh. That seems pretty simple, but it's harder when it gets down to a population level to say, I really want to make a difference and try to lower, like if I was leading the health department of a state or even an island, let alone a country, how can I affect these risk factors to lower my citizens' chances of dying from these diseases? And so the World Health Organization has made a list of what they call best buys that are financially worthwhile doing because they get a high impact for cost effectiveness. And this stat here, this 100 per DALY, it's a disease averted life year and disability averted life year, meaning it's how much does it cost for me to buy 1 extra year of health on average for the average person. They say, World Health Organization says $100 a year to help somebody live healthier for another year. That's a pretty good deal here. And then, is it even feasible to scale up? And I'm talking about like island nations that are so remote, that don't have any specialists and don't have a lot of resources and don't have, you know, the economy to support the chronic illnesses that we're talking about. So let's look at those 4 risk factors and what the World Health Organization recommends in order for a global risk reduction of dying from these non-communicable diseases. So I can sit in a room all day long with my patient that smokes and tell him, I think you should stop smoking, okay? And he may or may not take me up on it, and that's okay. But from a government perspective or from a public health perspective, what are some things that we can do? Well, if we raise taxes and prices on tobacco and make it less feasible for people to buy it, that's going to cause some people to stop. Now, unfortunately, they may start growing it on their own, or countries may switch to growing it on their own. So that's sort of an unintended consequence. But in general, that's one way to do it. I don't know if you've ever traveled overseas and seen some of the warning signs on tobacco packaging, but it's really ugly. Like, Amy, I see you shaking your head. What have you seen on tobacco packaging?
In Thailand, I've seen like rotting teeth. It was like really gross.
Yeah, exactly. And it's horrible, right? I mean, just ugly. Yeah. So they've got ways to ban advertising and promotion, like you can't have TV commercials for tobacco. And then where family physicians can come in is to provide medications to help with tobacco cessation. So that's that nicotine patch that we can prescribe, or the nicotine gum. And there's actually a 1-800-QUIT line that the state of Hawaii supports to help people stop smoking. And they give them counseling and medications to help with that. But this is a place where family physicians can help, and it costs less than $100 in order to get 1 fewer person to smoke, to either stop smoking or not pick up smoking. The second modifiable risk factor is to reduce physical inactivity. And I want to draw your attention to this picture in the upper right here. So it says here, an American Samoan dances in Ipo Himaloto's class, and this was on CBS News. So remember how I told you there was a medical student from a foreign country that didn't know about family physicians. Her name is Ipo Himaloto, and she's from Samoa, and she was doing a rotation here. And I was looking for images to put this lecture together. And I, as culturally insensitive as it sounds, I was trying to put in like Polynesian, exercise class, you know, health kind of, any kind of Google image search that might bring up something that would appeal to an audience out here in Hawaii. And I will be darned, this picture from Ipo Himaloto's exercise class came up, which really made me feel good. that here was somebody that didn't even know what a family physician was, and yet she was doing interventions. This was even before she went to medical school. She was organizing exercise classes in her home country. I just need to click something there. Bringing up interventions in her home country that were absolutely spot on with exactly what we're talking about for a family physician. So don't underestimate your ability to make a difference at a really big scale with simple things here. You might try to organize something for kids or maybe put out some advertising. Those are a couple of the best buys that the World Health Organization recommends. One of the things that I do for every person when they come in for their yearly physicals, I talk to them, what do you do for exercise? And I tell them I recommend 150 minutes of exercise each week. I don't care how they get it. It might be walking for 30 minutes 5 times a week, weightlifting, go swimming, whatever. But I talk to them about it at their routine primary care visits. So again, a family physician plays a key role in preventing this as a risk factor for non-communicable disease. Sorry. The next risk factor is reducing an unhealthy diet. And again, you can see I was sort of looking for Polynesian-ish images that might appeal out here to this audience. And you can see here's a poster that the World Health Organization put together and translated it into 6 different languages so that it could appeal to many, many different people out here. Trying to get people, number one, to breastfeed their babies. That was like one of the World Health Organization's best buys. And I say that for every single mom that comes in while they're pregnant and with their newborn, I try to encourage breastfeeding. And whether it's literally to find them a lactation consultant or at least talk to them and try to give them the support for breastfeeding. You see the other kind of choices that we kind of get people to make. It's hard though. So much salt in our food, so much trans fats in our food, but it's just a matter of educating people and helping them to make better choices. And then
I had a quick question.
Yes, ma'am.
So in that regards, like I know for like in North America, our food is very highly like processed and everything. So do you have like a recommended type of like cuisine or place in the world that has a good sense of like how they make their food and everything, if that makes sense?
Yeah, so there's a thing called the Blue Zones diet. Have you heard of that yet? So that's a sort of move to analyze the diets of people, I think in 7 different parts of the world that living to 100 is sort of common. There's a part of Southern California where people are largely vegetarian. There's an area in Costa Rica, there's Okinawa, in Japan, you know, out there. So they look at what do these people do? What are the spices that they use? What are the foods that they include? And they sort of analyze it and make the connection. Again, it may not cause them to live to 100, but it certainly helps them to have a higher odds of living a longer, healthier, more vibrant life. So I really love that Blue Zones diet. That would be something that would be well worth your time looking into. The other diet that is also very common to recommend is called the Mediterranean diet, that has a lot of fresh foods, but cooking with olive oil, for instance, lots of whole foods, nuts like almonds, that sort of thing, and a little bit of red wine because it does have some antioxidants in it. But so if I've got somebody that, you know, can get on the internet or can buy a book about the Blue Zones diet, I encourage them to do it, or at least this Mediterranean diet. Those are 2, like right off the top of my head, that if you Googled them, you could find them and it would be pretty obvious what it is that you're being recommended. That make sense?
Yeah, thank you.
Oh, sure. So, and again, actually, you know, it's probably worth pointing out that, you know, reducing an unhealthy diet is good in and of itself, but it's also an intermediate risk factor for diabetes, right? It's an intermediate risk factor for obesity and high blood pressure and high cholesterol. So not only is it just a good thing in and of itself to help you live to be 100, it's also known to be helps to eliminate risk factors for these diseases that we're talking about here. The other risk factor here that we can help people address is reducing harmful alcohol use. And depending on, who you are and what guidance you're looking at, I'm not here to judge, 1 or 2 drinks a day or whatever. But we do know that harmful drinking habits do contribute to deaths from non-communicable disease. And that's independent of I'm drunk driving and I crash my car, or I'm drunk and I get in a fight outside a bar, or those other horrific sort of accidental deaths. That's not what we're talking about here. One of the things that family physicians do is an acronym called SBIRT, S-B-I-R-T. It's screening, brief intervention, and referral to treatment. And if I have somebody that I'm getting the idea that they might have harmful alcohol use, there's this tool that might help me better identify them and help to get them the treatment that they need. And there's actually federal funding available to help support those programs. And so again, this bottom intervention here, this is something that I do with every patient that I'm screening for harmful alcohol use, is I can provide them with a brief psychosocial intervention to kind of help curb their use. All right, so let's talk about those 4 groups of diseases that account for over 80% of all non-communicable diseases. And actually, it's well over half of the deaths worldwide. And this is pre-COVID, and I get it that COVID has made a big splash, if you will, in the news. I'm not the one that's composing the numbers or putting reports on people's death certificates, but I do know if you've got cardiovascular disease and you get sick from COVID, it's going to be a rough road for you on recovery. If you've got cancer, if you've got a chronic respiratory disease at a baseline and you get exposed to COVID, it's going to be really hard for you to survive from that. So whether you call it you died of a heart attack because your heart had to beat too fast because you had a fever from your COVID, I don't know how to label those deaths. I do know that these 4 diseases, they take their toll worldwide, and this is regardless of COVID or not. So I'd like to talk about some of the different ways that family physicians can intervene for these 4 diseases. And there's some areas where we can help affect, but we need some help from specialists. And these are still in the $100 per disease averted life here, that best buy for World Health Organization. Getting somebody medication to treat their high blood pressure, that's HTN, hypertension, or to treat their diabetes is a best buy. It will lower your risk of having a heart attack. And that's especially if you're already at high risk for it. Like your dad had a heart attack, you're doomed to have one. Let's make sure we treat your high blood pressure, your diabetes. If you have a heart attack, it's cheap for me to get you some aspirin and help break apart that clot and help you try to survive that heart attack. Now, if you're in the hospital and you need a medicine that we call thrombolytics, that usually requires either an emergency physician or a cardiologist to administer, but it's a best buy if I'm able to follow you up after your attack and we see you in the primary care clinic. Treatment of stroke, that's when you don't have enough blood supply to your brain. With thrombolytics, that's the medicine that breaks up the clots, costs less than $100. Let's talk about this rheumatic fever. So the reason we treat strep throat with an antibiotic is not because you have a sore throat. It's to kill off the strep bugs that we know have the potential to attack your valves in your heart. And that's what rheumatic fever is that it causes a damage to your heart valves. We actually have had kids come in that didn't get treated for their strep throat. Maybe their family didn't have the money to buy the antibiotics, or they never took their kid to the clinic or whatever. Maybe they lived on an island that didn't have any doctors out in further and more remote areas of the Pacific. These kids have got rheumatic heart disease and they're having heart failure at the age of 10, 11, 12. I mean, they look like they got 60, 70, 80-year-old hearts and they're just kids. That's why we treat strep throat with antibiotics. It only takes a couple bucks for me to give you antibiotics to treat your strep throat, though. That's a pretty darn good deal if I can avoid the rheumatic fever down the road. What about managing diabetes? So this is a really, really complex disease that we all know causes you to have high blood sugar. I'll be honest though, the more I find out about diabetes, the more I realize I don't understand it at all, because we usually make this assumption that only fat people have diabetes, right? That's sort of this stereotype. But there are a lot of thin people that have diabetes. And then there's type 1 diabetes where you don't have enough insulin. And then there's type 2 diabetes where initially you have too much insulin and then eventually your body says, oh, forget it, you're not paying any attention to me anyway. And then you don't have any insulin after that. So you could have fat people that don't have diabetes. You could have thin people that have type 2 diabetes. It's really a difficult disease to figure out. However, we do know that giving medications to control blood sugars, watching people's feet to make sure they don't have any sores that aren't healing, and then they can avoid an infection and avoid the gangrene and avoid the amputations, getting them the insulin if they need it, getting them their flu shots, because these people are immune compromised. They're not going to do well if they get the flu. Giving them a medicine called an ACE inhibitor to help prevent damage of their kidneys. This makes a big deal monetarily, and I've got an example of that here in just a minute. Now, they also get eye problems, so I need an ophthalmologist to do these eye treatments here. This is not something that a family physician does. Nevertheless, it will also help to manage some of the complications and some of the morbidity, which is you're not going to die from being blind from diabetes, but your quality of life is certainly going to suffer because of it. Let's talk about how to manage cancer. So #1 risk factor is smoking, but there's these other risk factors, alcohol use, specifically like liver cancer, air pollution and asbestos cause different kinds of lung cancers. Let's talk about the best buys here. So what kind of cancer does vaccination against HPV, what kind of cancer does that prevent? Does anybody know?
Cervical cancer.
Yay, cervical cancer, exactly. And so vaccinating worldwide against HPV, again, it costs just a couple dollars, and we have the potential to prevent cervical cancer worldwide. The other way that we can do it is to inspect a cervix early before cancer has taken place and treat it before it actually turns into cancer. So that could be visual inspection through a number of different ways. It's not expensive. I can do that any day of the week. Easy stuff. Now, breast cancer screening is a good bargain, but it's only cost effective if you have people that can take care of it. So you have to have a surgeon to do a mastectomy. You have to have a cancer center in order to give chemotherapy. Those are not treatments that a family physician can do. And then there's palliative care for cancer that will help people have a longer quality of life, even if they have the diagnosis. Let's talk about managing chronic respiratory diseases. So we're talking about asthma and COPD, which are, for the sake of this lecture, sort of two sides of the same coin. There are medications that are quick-acting rescue inhalers that will help someone with a acute attack of asthma or COPD. And then there's long-term treatments that help to avoid the attacks. And so the quick rescue one is abbreviated SABA, which is a beta agonist that works on the smooth muscles in your lungs. Then there's the ICS, is the inhaled corticosteroid. That's sort of like hydrocortisone, except you inhale it and it goes into your lungs to kind of stop the inflammation. So those medicines are not expensive. You don't need brand names, and they've been around forever. Those are easy medicines to have. I prescribe them every single day to patients here in Hilo. Easy to do for a family physician. So again, if you're at the population level and you're in the government or you're at the health department and you say, I really want to get the most bang for my buck, I want to hire a family physician and let them do their thing with people, I can take care of your respiratory diseases, no problem. We got to get people with these chronic illnesses their flu shots, because they will get very sick very quickly if they get the flu. I need to coach people to quit smoking, back to that risk factor we talked about earlier. and I need to help decrease indoor air pollution. Now, this is a bigger problem than I ever even imagined. That's probably the single most important strategy worldwide for preventing chronic lung disease, and this affects women in particular and children. Nearly half of the world's population relies on solid fuels for cooking their food. So we're talking about traditional stoves and wood, and it's usually inside, and so they're breathing in all of this smoke. There's this really interesting organization that's the cleancookingalliance.org reference that I have there. They help to get clean cooking fuels to poor countries worldwide to help reduce their risk of these chronic respiratory diseases. It really looks like an interesting organization. Excuse me. I think we've got about 15 minutes or so. Let's kind of we'll sort of pick up a little bit of speed here. So there's sort of minimal tests that I need to be able to do at the primary care clinic to address non-communicable diseases. Those are pretty easy tests. I don't need to describe those for you. And there's a fairly short list of medicines that I need to have available in the primary care clinic to address. This is 80% of the non-communicable diseases causing half of the deaths in the world. If I have those medicines there, they're not expensive. I can help people live longer and healthier. So let's talk about global health security, and this is sort of where we are in the international realm. So the concept of health security was first described by the United Nations in 1994, and that's a concept that takes public health activities to help minimize the effect of health effects across geographic areas. So within a country, you might say, or across an island. And this is so that a country can survive COVID, or can survive a tsunami, or can survive malaria. And it usually makes reference to infectious diseases. Global health security, so adding on that term global, refers to efforts that go across international boundaries. So regional, and it might be different political areas, it might be different countries, might be like us, US, Canada, Mexico. Are we all having the same effort? Because the COVID virus doesn't know that it's in the US and it won't go into Mexico, or vice versa, right? It doesn't hear that there's a boundary. So I would like to advocate that non-communicable diseases be at least as important on the global health scale as infectious diseases are. And in 2011, the UN had a meeting on the prevention and control of non-communicable diseases. And this is only the second time that the United Nations held a meeting like this on a medical issue. The first time they did it was to discuss HIV. United Nations is obviously an international organization, and it's not just doctors and nurses. This is, a whole range across a country's, whether it's politics or religious leaders. They're representatives of their country to the United Nations. So not just doctors, not just nurses. The reason I advocate that we all know about this is because, first of all, non-communicable diseases cost a lot for a country to try to eliminate. And if a country is fighting the cost of these non-communicable diseases, that means they have less money to spend on educating their children and developing their infrastructures and providing jobs and all of those other things. Non-communicable diseases also increase inequalities between populations. So if you are somebody that is at risk for chronic respiratory disease because you use solid cooking fuels, for instance, and the person that lives even on the other side of town that uses electricity or natural gas that isn't at the same risk, you are going to be sicker and have less quality of life through no fault of your own. And there's an inequality there that can't be bought, right? I can't just give this person more money and make it better. It just is what it is. So the World Health Organization's #1 objective for tackling NCDs is to raise the priority worldwide for the visibility of non-communicable diseases. And so I'm just doing my part today to help spread that message for the World Health Organization. I want to give you two examples of what I'm talking about here on the impact of non-communicable diseases and specifically prevention. So have you heard of Vanuatu before? Vanuatu is a small island nation, population's about 250,000. Their government spends about $157 per person per year. So mathematically, that's about 50 cents a day on health. Unfortunately, diabetes is rampant in this country. And for every person that I can prevent developing diabetes, I save their government $347 a year. They only budgeted 50 cents a day for me, or $157 a year. And if I develop diabetes, that means I'm taking away resources from two other people, right? If they have to spend $347 to take care of me and my medicines and my health problems, that wasn't money that was budgeted for that. So I want to prevent diabetes. And if I can prevent them from having to go onto insulin, I save an additional $484 a year. So these are island nations that don't have a huge infrastructure and don't have a lot of money in the bank to just say, oh, well, we'll just spend way more than this 50 cents a day on this particular person because they don't have the budget for it. And this is from an article from 2012 that was actually kind of interesting on the economic cost because it specifically focused on the Pacific Islands. So this prevention of diabetes and prevention of progression with the use of insulin, this is what a family physician does. So let's look at a different condition. So kidney disease, and this is from, from that same article on non-communicable diseases in the Pacific Islands. Another island nation, again, we'll just say they spend about 50 cents per person per day on health programs. Their National Kidney Foundation gets about 7% of their total health money, but less than 5% of that goes to prevention of kidney disease. The bulk of it goes to treating kidney disease, and the bulk of that goes to hemodialysis. 1 year of hemodialysis for somebody who's had kidney failure costs $40,000. So back to their budget, they only budgeted $180 per person per year. If one person needs hemodialysis, I don't even want to try to do the math. What's that, 200 people that they have to divert the money from? That's a lot of people then that will have to go without. The problem is it's not even money that's very well spent because a third of people die within a year of starting the hemodialysis. So they spend all this money and they don't really give the person a better quality. Or the irony of it is, back to my risk factors, the two main causes of kidney disease are high blood pressure and diabetes. Remember how we just spent a few minutes talking about how family physicians help to prevent it, and there's different interventions both at the primary care level and at the international level to help prevent those two diseases. So family medicine and even physicians in general are just one part of what we call like a whole of government approach to addressing non-communicable diseases. And the World Health Organization actually has a really it's sort of, when you have free time, an interesting repository of their policies to address non-communicable diseases worldwide. I took a screenshot here from Afghanistan, alphabetically, that was where they started. So they've got nutrition strategies, they've got smoke-free strategies, they've got other strategies. And this is in one country in a part of the world that I pray none of you will ever have to go visit. I've been there, I was in the military for 20 years, so I could tell you all about it. But I'm happy that they have these policies because even in Afghanistan, they recognize that they need policies and systems to address these problems, to kind of like that comprehensive approach. So this is a guidebook that was published by WONCA, that's an international organization of family physicians, that they show how family medicine can contribute throughout the world to make health systems more productive and coordinated and cost effective. We have rigorous preparation. I talked to you about the residency programs. We coordinate care and linking the patient to the community and the resources that are there. And we have flexibility that allows us to serve in pretty much any kind of setting, across boundaries, across different kind of health problems. So one quote here from the Milbank. This is an endowed organization that works to improve population health. They look at evidence from research here and they sort of summarize it, talking about the great investment of primary care, that it provides medicine at a lower cost with higher patient satisfaction, fewer hospitalizations, and lower mortality. And they point out that areas that have higher percentage of primary care physicians spend less and have higher quality of care. So that's the end of my presentation here. I hope I gave you some of the objective data for why family medicine, sort of at the global level. And I hope I gave you an idea of what family medicine is in terms of a specialty that you might consider when you are done with medical school and you're wanting to choose your residency. I'd love to pause for a couple minutes. I think we've got maybe 5 or 10 minutes left here, Alyssa, or I'm not sure who else is on there. Are there any questions or comments?
Yeah, I'd love to open the floor for anyone who has any questions. Like, go ahead and unmute yourself if you have any.
I guess I can start off. I've been interested in family medicine since I decided to go to medical school, and right now I'm more interested in working on an international or more of a global scale. I love traveling and I like medicine, so I was like, oh, why not family medicine and some sort of traveling doctor? But when you mentioned that the training that family medicine physician gets in the US differs from Canada, I'm pretty sure it differs from country to country too. Is there like a sort of central training that we or like family physicians go to before they're like released to the wild or something, for lack of a better term?
Well, first of all, Amy, thank you so much. So if you had been the only person that showed up tonight, my time would have been worthwhile, because that's exactly what I was hoping to get across is the world needs more family physicians, and it's not sexy and it doesn't make the news and we don't make much money and we don't get a lot of attention or medals or anything else. But I showed you here from a global perspective, we're a pretty good deal for people to want to include us in their systems. So Wonka was the one, if you remember at the beginning, that they laid out, here's the minimum core competencies, regardless of what country you're in or how you get them there. There's the minimum core competencies of a family physician. The US lays it out very, very specifically, how many patients you need to see in the clinic, how many hours you need to spend in the ICU, how many babies you're supposed to participate in their care as a newborn and in the hospital. And they're like embarrassingly specific. I can't really comment. There are other countries that have family medicine residency programs that are similar. I understand like Australia and New Zealand have pretty similar training programs to the US. Canada is very similar. I'm sorry that I don't have personal experience working in any of those other countries or in their residency training programs. I obviously have a bias because I know the kind of physicians that we turn out and the kind of standards, academic standards, competencies for cultural understanding and professionalism and systems-based care. I know that that's what we can do in the US. There are lots and lots and lots of positions for family medicine training in the US. So I'm, obviously I have a bias that I would like you to stay in the US to train, regardless of where you go for your service afterwards. But you might go to the Wonka website. It's all free to go look at that and see where other training options might be. I personally am, like I say, I'm biased, but doesn't mean you can't get good training elsewhere.
Right, thank you. And is this like already incorporated in the US residency program for medical schools, or is this like a totally separate thing that we have to register for? Or I probably missed it in the beginning, I'm sorry.
Yeah. So you, after college, or like your senior year of college, you start applying for medical school, right? You take your MCATs and you say, well, I think I'd like to go to a small school, or I want to go to a state school, or whatever your wish is. I happened to do my residency, or excuse me, my medical school in Wisconsin, mainly because I grew up in Washington State, and I knew that if I stayed in Washington State, I probably would never make it through med school, because all my friends and all my family and everything I enjoyed doing was all right there. I knew I had to move away in order to like focus, right? Because it's no joke, right? And so I went to the Medical College of Wisconsin. I sort of got there just by happenstance. I mean, my dad was a truck driver. My mom was a secretary for the sheriff's office. They never got in my way. They always said, "Okay, well, good luck, honey. You know, best wishes." But they didn't know how to get me there. So I'm figured out my way into medical school. But it turns out the Midwest has really good training programs for family medicine physicians. And so I stayed there to do my residency training. Um, we have great programs here, largely because there aren't a whole lot of specialists. Now, it might be more difficult to get a good, this kind of residency training, maybe in an area like New York City, for instance, where there's just gobs and gobs and gobs of specialists, right? So they want to train their specialist providers, not so much their primary care providers. So you're going to find a medical school that might be geographic, a place you want to go, and you might say, I want to stay in Hawaii, and Oahu is great, and I want to stay here and go to JABSA. Absolutely, you will get an excellent education here. After your 4 years in medical school, or about like at 3.5-year mark, you start saying, I think I know what I want to be when I grow up. You already know, Amy, so you don't even have to go through this exercise. I want to be a family physician. And so you start preparing yourself for family medicine residency, which would be a 3-year program after medical school. So minimum 4 years of college, 4 years of medical school, and 3 years of residency. Don't shake your head, Alyssa. I made it through. You can make it through too.
I'm gonna tack on one last question. I might push us over the mark if that's okay with you.
That's no problem.
I just wanted to throw this in as kind of the obligatory question for these days. What has your experience been with COVID as a family physician?
So COVID has been a struggle on a number of ways. So I serve as you see here, I serve as the medical director for the East Hawaii Health Clinics. So I'm responsible for the clinic here at the hospital. We have a clinic right across the street at where the cancer center is, where the Cross Wainui. We have a clinic down at Puna Community Medical Center in Pahoa. We have a clinic out at Ka'u at the hospital in Pahala. We're developing a new one in Keau. So we're doing primary care all across East Hawaii because everybody knows we don't have enough doctors out here. And so a lot of primary care requires me to have face-to-face with the person. Actually, I can't do a pap smear over the phone, right? I can't give you a tetanus shot over the phone. But it caused us to be a little bit creative and say, well, wait a second, if I'm refilling your cholesterol medicine and coaching you to stop smoking and taking care of your depression and filling your high blood pressure medicine, do I really need you to be here for that? Or can I do it over Zoom, for instance? So our hospital is one of numerous throughout the country who developed a platform that allows us to have a virtual visit, just like we're doing right here. And there's a lot I can assess about a patient. So if Amy were my patient here today, and I'm thinking objectively, how could I describe her? Well, she's not in any distress. She's not having to breathe hard. She's making good eye contact. She's making smiles, and if she obviously hears me. She doesn't appear to be depressed. And she might say, well, hey, look at this rash right here. Does this look like anything serious to you? And so I can do that as well. So I don't really need people to be face-to-face, right? I can actually get quite a bit of information, especially if they're doing their blood pressure at home and they're checking their blood sugars at home and maybe doing like an exercise diary or whatever. I can get quite a bit of information at the primary care level just through a platform just like this. So it's it's caused us, what do they say? Necessity is the mother of invention, right? The people still need their care, but they're terrified of coming in the hospital. Also in, February, March, when we were all planning, we thought this was just going to explode and just take our island over. And remember, I just said, we don't have enough doctors here. Like, we were ready to get seriously hosed. And so the people in my department here, we developed a alternate work schedule that would allow us to work 24-hour shifts and see people out in the breezeway of the hospital, out in front of the emergency room. Because if you have COVID and you don't need to be hospitalized, I don't really want you anywhere near here. So if you're not low oxygen and you don't have these other chronic illnesses, just go home, stay by yourself, have some chicken soup and get better. And if you think you might have COVID, but you don't have COVID, I don't want you anywhere near here because you're going to get exposed to people that have COVID. So we developed a kind of a triage tent to assess people in their car and say, well, you're not low oxygen, you're breathing fine, you're able to get up and go to the bathroom without getting short of breath, you're pretty healthy at baseline, please just go home and don't come in the building. Blessedly, we were not forced to enact that yet. We're still prepared to do it if we have a big wave and our hospital is overwhelmed and our emergency room is overwhelmed and we have to kind of triage what care we have available for people. Thankfully, we haven't had to do that yet, though. People have done really, really good job of the social distancing and the wearing a mask and try to stay home and blah, blah, blah. And that's all, that's what this takes, right? I mean, there's nothing exciting about that.
Okay, that was actually really insightful. Thank you so much, Dr. Walker. On behalf of all of AMSA, I know a lot of kids actually couldn't make it, so you're going to be a YouTube star in these next few days.
I would have worn lip gloss if I'd have known.
Yeah, but you're all good. Yeah, so I think that marks the end of our time. Yeah, I think I think you were good to go. Did you have any questions or concerns, Alyssa or Dr. Walker?
Yeah, so again, thank you so much for inviting me. Excuse me. I'm happy to talk to any of you one-on-one. Please take down my email address here and send me a note at work, and we can arrange to go have a coffee, or if you want to come by the clinic, or we'll figure something out. I don't want you getting exposed to COVID. But I'm also happy to come speak to you guys on a topic. If there's a specific topic or you have other meetings that you would like to hear from me, I really feel strongly that it's my job to help mentor and coach people that are coming along. And part of it might be because I didn't really have any of those people for me. And I suppose I would have listened to them if they had been there, but unfortunately I really didn't have any family or anybody to sort of role model any of this for me. So I'm very happy to see you guys having this group here, and I would very much like to continue supporting it.
Thank you so much. We really appreciate it, especially because during these times it's hard to find people willing to give up some time, especially with being a doctor and how hectic things are in the healthcare field right now.
Well, and you can see I'm a really big deal too, so it took a lot of my time. Sort of a big deal, right? All right. Have a good night, ladies. Thank you for inviting me.
Thank you.
For coming.
Good night.
Bye.
Good night. Thank you.